Hello, everyone. Thank you for coming to my capstone presentation titled At the Root of It All, What's Screwy About Implants? My name is Zylstra. My contact information is below. If you have any questions or if you're a first-year student looking to piggyback on this capstone, I'd be more than happy to answer any of those via email. Oh, come now. There we go. Come on. Before we get started, I'd like to acknowledge a few very important people in this project, specifically Dr. Greeny and Dr. Bonfiglio for not only getting this project off the ground and getting it running, but their encouragement along the way in editing my paper and the publishable manuscript, as well as everybody else you see on this screen. Thank you very much for all that you do for us as students and this program. So what is a dental implant? A dental implant is made up of three parts: a crown, an abutment, and a screw. And all of those pieces sit together within a patient's alveolar bone. And so dentists have to, in placing an implant, they have to pull the tooth that was there, the diseased tooth. And a lot of times they have to graft the bone and the tissue that's there, let that heal, and then they will screw this screw into the bone that they just grafted, so into the existing bone. And nowadays, with technological advances, dentists are using CT scans, or specifically in this image that you see, cone beam CT, a particular low resolution, low exposure form of CT scan, to visualize and diagnose bone levels and bone density. So you can see here in this bottom image, the level of bone coming right up to the crown, and this different shade is actually indicative of bone density within the jaw. And then you see here in the top corner a 3D representation that was made from these three windows put together. And so, like I said, the diagnosis is using cone beam CT, but that's it. So our research question is centered around, what if we could use cone beam CT for more than just diagnostic material? And so we've hypothesized that a 3D printed dental implant that mirrors the patient's current dental root structure is achievable through the same images that you saw on the previous slide, basically making a model from those different images of the cone beam CT. But before we can even address that hypothesis, we needed a standard of measurement to see how close the CT models are to the actual patient's tooth. There's speculation as to the accuracy of cone beam CT, but as far as the actual dimensional accuracy, for this study, we're not sure. And then on top of that, what type of CT do we use? Do we continue with the standard protocol of cone beam CT? Should we use medical CT, which is a higher resolution but a higher exposure? Do we go all the way to, say, micro CT, which is even more exposure but even more specific? We don't know. And so the first thing that we needed to do was create a standard for our CT models. And to do that, we used the Trio scanner software in the dental school. This is my hand on the right with the mini camera. It just takes hundreds of pictures of the teeth, and this is referred to as an optical scan or a digital impression technique. It's usually used as a substitute for those goopy composite compressions that make everybody want to throw up. But we used it to make these models here. So you can see in this slide, we have three images of the same tooth, and these software renderings of the tooth on the previous slide are within 10 microns of that actual tooth. And so we trust this. There's literature backing that number. This is our standard that we're going to work with to compare other digital 3D models from the CTs. Next, we needed to segment out individual incisors from the cone beam CT and the medical grade CT images. And so you can see here using 3D Slicer, it's the same program that the first year MHA students are taught to use. We have segmented out three different individual teeth in different colors, and you can see them represented here in the window, their respective planes of view. Once we had these segmentations in Slicer, we exported the models and then imported both our model and the optical scan digital impression into this software called Cloud Compare. And we used Cloud Compare to do a mesh to cloud distance comparison. So on the left, you can see the segmentation model that I created from cone beam CT. And on the right, you can see the actual optical scan of the patient's tooth that was performed with that mini camera. Once we had both of those models imported, I overlaid them and then developed a color map to show in green where it's spot on, red where it's a little bit high, and blue where it's a little bit low. And then on the right, we have a histographical representation of that same color map. Showing down here on the bottom, you can see this scale is actually in fractions of a millimeter. And we have 100% of the cone beam model falling within half a millimeter of that optical scan digital impression, which is great. That's what we were shooting for. We were happy with that. But not all of the teeth fell within that half millimeter 100% of the time. And so after we had collected every single sample from both cone beam and medical grade CT and run this comparison, we had the histographical representation of how much of the tooth fell within half a millimeter. And then we averaged that percentage value to show across the entire sample how much fell within the half millimeter. So for med CT, we had an average of 92.5% of a tooth fell within the half millimeter mark, plus or minus. Subsequently, the cone beam CT average was a little bit lower, 85.5% within that half millimeter range. But if you look on the right at the descriptive statistics table, we have a cone beam CT sample size of 10 and a med CT sample size of 5. Of the 10 samples that we tried to get, we were only able to get 5 or half of those samples from the med CT due to the fact that patients who had previous restorative work done caused a flare in the CT images or noise. It was not possible to segment out specific teeth always for med CT, whereas we had a much higher reliability and much higher success with the cone beam CT in that regard. Our conclusion for that then is that the cone beam models were 85.5% accurate to within 500 microns or half a millimeter of the actual tooth's dimensions, which is fantastic. CBCT was slightly less accurate than the med CT, but it actually proved to be more dependable given any random sample. So this study would suggest or support that cone beam imaging techniques can be used as more than a diagnostic tool. We proved that successful segmentation, model exportation, and mesh-to-cloud comparison could be viable avenues for developing a 3D printed dental implant therapy. Our future directions, this summer, I'm going to be working with the dental school summer scholarship program to perform the same procedure in a larger sample size and with in vivo subjects to strengthen the validity. This study was done with cadaveric samples, and so the periodontal ligament may have calcified due to old age or fixative agents, and so we want to see what it's like for actual patients who are getting an implant. The next thing would be to construct a 3D printed model from the cone beam digital models that we now have, and then put that through finite elemental analysis and load-bearing tests. For the MHA Year 1 students who are watching this is a potential capstone that you can hop on. If you have questions, please email me. I'd love to have somebody on this project with me. And then from there, we would take it to animal model testing and then human testing way far down the road before we have a commercializable product. Any questions? Thank you.
Excellent work, Zach. Any questions? You have a raised hand. Go ahead, Alex.
Hey, Zach, good to see you again. Good to see the MHA community. Nice presentation. Practically in the dental practice, where do you see this going? And do you think it could be implemented in a wide range to improve crowns in patients? Or is this right now more of a just a laboratory procedure and yeah?
So that's a good question, Alex. Thanks. Really, the hope for this would be to get it to a point where we could have a commercializable product that proves just as reliable as the implant therapies that we have now. One of the main motives behind this is that for patients who need an implant, if bone grafting is necessary and the rest of their bone density and their sinuses are all healthy, Grafting adds on about another $2,000 to the procedure. And so for patients who fall into that category, we could potentially place an implant that mirrors their tooth structure without necessary bone grafting and save them significant money. So that's kind of the clinical goal of this project. However, right now we're still trying to prove that our accuracy of the models mirrors what we're seeing in the laboratory digitally.
So following up on that, Zach, how accurate do the dentists want it to be? Like 85%, 87%, 93%? Is there a cutoff line, or?
I'm glad you asked. So there hypothetically should be and would be a cutoff line. However, if you look at this next slide that I prepared for just such a question, because I didn't have time to talk about it in my actual presentation, we have sources
didn't pay me
supporting.
to ask this question, by the way.
Oh, did I? I don't
No,
remember.
you did not. No.
Maybe
Really?
your husband did, because he's heard me talk about it for forever.
No, I was.
That's okay. These are two articles supporting the dimensions that we chose. And so we found that under contouring an implant by about 0.5 millimeter still allows for osseointegration without grafting. And then on the flip side, over contouring of about 0.6 millimeters still fits into the hole. So we shot for that 0.5 millimeter. However, if it was under in certain parts of the implant in certain faces, you might still have close enough contact in other places to still get osseointegration started. There's this technique called a delayed immediate implant, in which the osteoid or immature bone has already started to form when they place the screw, and that really catalyzes bone development. And so even if it was a little under contoured, if you had good contacts in some spots, it would still probably integrate just fine. And if it was over contoured, a dentist would be able to, they've taken tooth morphology and tooth anatomy, they could shave down the high areas and make sure that it fit their needs potentially.
What's the accuracy of the gunky molds?
Sorry, what was that?
You were saying that gunky molds that you gag when you put in.
Yeah. So
how do those perform?
The impression material that dentists use that make you want to throw up is still a very accurate tool and technique. However, we don't have a way to build a 3D model from that physical goop.
Yeah.
So it's just as accurate as the digital impression, just the digital impression fit our needs in regards to being able to compare something on a 3D software manipulator.